I'm Sasi, medical liaison from Novartis. I would like to welcome everyone to this week's Heart Failure Conclave. So today we are joined by two distinguished speakers from CVSKL Malaysia. Dr. David Chew, consultant cardiologist, who will be chairing the session, and Prof. John, cardiothoracic surgeon, who will be discussing with us on a vital topic, which is management of valvular heart disease in heart failure. Prof. John is recognized internationally, particularly for his work on heart valve diseases, and is a Hunterian professor at the Royal College of Surgeons of England, UK. Is also the honorary secretary of the Malaysian Association for Thoracic and Cardiovascular Surgery, and has responsibility for the training and of cardiothoracic surgeons in the country itself. He has also recently published a textbook on functional and mitral tricuspid regurgitation and has numerous publications in major peer-reviewed journals. So without any further ado, I would now pass the time to Dr. David Chew for the opening remarks and to kickstart the overall session. Dr. David.
Thank you, Sasi. It's my pleasure to chair this session. I'm a consultant cardiologist at CVSKL. Now we know that heart failure is an increasing problem. A survey using echo in patients with suspected heart failure found that about 14% of patients have moderate to severe valvular lesions. So valve disease in the setting of heart failure is a challenge. Firstly, valve disease can cause heart failure itself, and if the valve disease is the cause of the heart failure, then treatment of the valve disease can correct the heart failure. And usually to manage valve disease, because it's a mechanical problem, the surgeon is often involved. Heart failure itself can cause dilatation of the chambers of the heart, and this can lead to functional valve problems, typically functional mitral and tricuspid regurgitation. And in the management of this condition, the valvular condition, it can be with medications, it can be with devices, or it can be with surgery. To talk about these interesting and challenging problems in patients with heart failure, I would like to introduce my colleague, Dr. John Chan. He graduated from Nottingham. He actually got a British High Commissioner Scholarship to study medicine. And when he was in the UK training for his cardiothoracic surgery, he actually did a Master of Science in Clinical Trials and also had a PhD from Imperial College. Interestingly, his thesis for the PhD was a trial called the Randomized Ischemic Mitral Evaluation. This was a trial of patients with coronary artery disease and mitral regurgitation, and was randomizing patients to either bypass surgery or bypass surgery with mitral valve surgery. And after his stint in the UK, he came back to work as a cardiothoracic surgeon in Sarawak GH, and then in Gleneagles KL. And for the last 2 years, he has been my colleague in CVSKL. So without much ado, I would like to invite John to talk about optimizing the management of valvular heart disease in heart failure. John?
Thank you, David. First of all, I'd like to thank Novartis for organizing this event. What a great idea to have a session on optimizing the management of patients with valvular heart disease and heart failure. Can you see my slides?
Yes, we can.
Okay, so I think we have a mixed audience here. So my talk will include some basics and also some, of course, we will cover the details. So I hope there's something interesting for everyone and you will find it interesting and exciting for the next half an hour. So in this talk, I will cover the types of heart valve disease, the pathophysiology and heart failure, of heart valve disease and heart failure, the natural history and outcomes of heart valve diseases, optimizing management according to the etiology and stage of disease, and then we have some questions and answer. I thought I would do it a bit differently in this presentation, in that I won't go through this in the sequence as listed, but rather I would use case examples, and we will cover all of these topics as part of different cases. So hopefully this will be a little bit more interesting. So as I was preparing this presentation, I suddenly realized that there is actually quite a lot to heart valve diseases, because there are 4 valves, as we know, and 3 of them cause problems in adult patients: the aortic valve, the mitral valve, and the tricuspid valve. But I won't be able to cover all of this. So in this presentation, I will focus on mitral regurgitation, particularly degenerative mitral regurgitation and functional mitral regurgitation, both non-ischemic and ischemic functional mitral regurgitation, and also functional tricuspid regurgitation. I won't cover the rheumatic, and I won't cover the aortic valve. I think we can have another session because otherwise the presentation will take too long. So if we start with the mitral regurgitation first, degenerative mitral regurgitation, the most common cause in this country, we do have a lot of rheumatic heart valve diseases, but in the cities like in Kuala Lumpur, the most common cause is degenerative mitral regurgitation, and typically due to chordal rupture, where one of the cords which supports the mitral valve has ruptured, causing the leaflet to prolapse, and with resulting mitral regurgitation. We also can have myxomatous disease, and this diagram shows a more extreme form of myxomatous disease in Barlow's disease, where we have lots of excess leaflet tissue so that there's no coaptation between the leaflets with resulting mitral regurgitation. Rheumatic mitral regurgitation is common in this country, as well as rheumatic stenosis, and that is due to fibrosis of the valve leaflets. So this is an example of a patient I treated some time ago. She's 71 years old, and she had been previously fit and well, and then suddenly she felt she was short of breath. She couldn't go shopping anymore, and this is what we found on echocardiography. You can see these are the 2 leaflets, that there is a ruptured cord, which you can see there, with the resulting that the posterior leaflet is prolapsing, and then there is significant mitral regurgitation. And her heart, the left ventricle, had dilated mildly, and the ejection fraction had gone down a bit. And the regurgitation was graded as moderately severe with an ERO of 0.4. The coronary arteries were normal. So we have a question for you now, and I think, yes. So how would you manage this patient? I think you could choose your answer, either optimal medical treatment, or optimal medical treatment with mitral valve repair surgery, or optimal medical treatment with mitral valve replacement surgery.
To all attendees, the poll is now open. You may choose your The poll is now closed. 22% chose answer A, 56% chose answer B, 22% chose answer C.
Okay, that's good. So let's carry on. Can you see my slides here?
Yes.
Okay, so so in that particular patient, clearly with the valve, with the mitral regurgitation, the problem of volume overload results from the leaking heart valve. And if we were to leave that alone over time, there is then this pathophysiological process occurs where there's progressive stretch on the walls of the ventricular chamber, a slow loss of cardiomyocytes over time, and then with time, with myocardial fibrosis will set in, with reduced contractile function, and conduction abnormalities and heart block will result. And if left untreated, further heart failure will result with activation of the neurohormonal systems as well as the autonomic nervous systems. And these patients with severe mitral regurgitation are at risk of sudden cardiac death, and this can be a result of ventricular arrhythmias or bradyarrhythmias, or even an acute contractile failure of the ventricle. So the whole point of management of these patients is to interrupt this cycle, preferably to prevent all these processes from occurring. And the earlier we intervene to stop these processes, the better the outcome for the patient. So depending at what stage the patient presents, various management and treatment modalities are available. So of course, if the patient presents with all these pathophysiological processes already in place, then all of the medical treatment would be advantageous in terms of improving their symptoms and also their survival. So we have the beta blockers, the ACE inhibitors, the ARBs, the ARNIs, the MRAs, the SGLT2 inhibitors. And if these are still, if the patient is still symptomatic, then there are other options like CRT, if appropriate, and also valve surgery. And of course, to prevent sudden cardiac death, antiarrhythmics in place, and also the ICDs. So what has happened in that patient typically is what is shown here. A cord of the posterior leaflet has ruptured, and the patient has developed mitral regurgitation. So in this particular patient, in the case of degenerative mitral regurgitation, where the primary pathology is a mechanical problem, the best treatment is to repair the valve, to fix the mechanical problem, and to prevent the pathophysiological processes from occurring. So there are various ways to repair the mitral valve, and this is just one of them. This particular patient had a condition which is probably the easiest of all the lesions to repair, because the problem was that of a ruptured cord. So to repair this, all we need to do is to replace the ruptured cord with a new artificial chordae, which is made of Gore-Tex. And this is illustrated in this diagram. In the case of patients who have excess leaflet tissue, we can repair the mitral valve by means of leaflet resection to restore the two leaflets of the mitral valve to the correct shape, and so to restore the competency of the mitral valve. So the risk of surgery in this particular patient was about 1%. We have various ways to estimate the risk for the patient. We use the Euroscore. The Euroscore was 0.95, so that translates to a risk of 1% for surgery. And she had a 5 to 7 day stay in hospital, which is quite typical. After 4 weeks, she is fit enough to drive again. The full recovery is 2 to 3 months after surgery for the wound to heal completely. After mitral valve surgery, it is important that the medications are continued. So after mitral valve repair surgery, they need to continue on antiplatelets for 1 year. Some would put them on anticoagulation, but in most cases, we treat them with antiplatelets with some aspirin for 1 year, and that is sufficient. It is important to control their heart rate and blood pressure after mitral valve repair. And the lower the heart rate, the better, and the lower the blood pressure, the better. You can think of this as minimizing the stress on the repaired mitral valve. So it's important to maintain them on medications as well after surgery, and as well as medications to promote reverse LV remodeling if the left ventricle had already dilated. And of course, important to remember that even though we have repaired the mitral valve and not replace it, antibiotic prophylaxis is also important for dental procedures to prevent endocarditis. So in this patient, she had aspirin for 1 year, beta blockers if the heart rate was above 80 or she's hypertensive, and then one of the medications for LV reverse remodeling, either an ACE inhibitor, an ARB, or an ARNI until the LV returns to normal size. The natural history of severe degenerative mitral regurgitation is well known, and this is one of the early studies published by Meng et al. In 1996, where he looked at what happened to patients with severe degenerative mitral regurgitation treated medically. And you can see that if we treat them just with medications, at 10 years, 90% of the patients would either have died or have needed surgery, 80% would have needed surgery, 60% would have gone into congestive heart failure, and 30% would have gone into atrial fibrillation. So in other words, this is a condition in which the patient will need surgery within the next 10 years. More recently, we now know that the earlier we do the surgery, the better the outcomes for the patient. This is a study from the Cleveland Clinic, and where they've demonstrated that in patients who have mitral valve surgery when they are asymptomatic, when the diagnosis of severe mitral regurgitation has been made, if they undergo surgery at that stage, their 20-year survival is a lot better compared to patients who wait until they develop symptoms before they have surgery. And if they wait until they have severe symptoms when they're in NYHA class 3 or 4 before they have surgery, then their 20-year survival is not as good. So and that has led to the change in the guidelines now to recommend surgery for severe mitral regurgitation if the mitral valve can be repaired, even when the patient is asymptomatic, because the long-term survival is much better in this case. And we know also that comparing repair versus replacement, it is much better to repair the mitral valve than to replace it, because it is all your own tissue, and the survival has been shown to be better. But of course, it is not always possible to repair all the mitral valves, but whenever possible, it is best to repair the mitral valve rather than replace it. In most cases of degenerative mitral regurgitation, it is usually possible to repair the mitral valve with very good results. It is a little bit more challenging in the case of rheumatic mitral valve disease, where a valve replacement may be needed. So that is degenerative mitral regurgitation. We now move on to secondary or functional mitral regurgitation, where the mitral valve apparatus is actually normal, but the primary pathology is that of the left ventricle, the heart failure. And in this diagram, you can see that the heart has dilated due to heart failure, due to dilated cardiomyopathy. And because of that, it has pulled the papillary muscles and the chordae, which supports the mitral valve leaflets, leading to what we call tethering of the valve leaflets. And because there's no coaptation between the leaflets, there then is significant mitral regurgitation. So the management of these patients are very different from the management of patients with degenerative mitral regurgitation, because here the primary pathology is that of the left ventricle and heart failure. So the treatment of this has to then focus on the treatment of the heart failure. So this is a patient who I saw about 2 years ago now. He's 56 years old, and he had got breathless on mild exertion. He used to be able to play golf, and he can't play golf anymore. He had some degree of pulmonary edema. His NT-proBNP was 12,000. And you can see that he had severe LV impairment. His ejection fraction was 20%. The heart was dilated with a systolic diameter of 57 millimeters, diastolic diameter of 63 millimeters. And you can see he has moderately severe functional mitral regurgitation with an EROA of 0.3. You can see the two leaflets are particularly restricted because the ventricle is so big and not contracting very much, and there was significant mitral regurgitation. The coronary angiogram was done, and the coronary arteries were normal. So we have a question for you again. How would you manage this patient? Optimize medical treatment or recommend a mitral valve repair or replacement in addition to optimal medical treatment? Oh, we're a bit divided. Okay. So we're split 50-50. Okay. So let's go on and hopefully we can get some answers. So the aims of any intervention and the aims of intervention in secondary mitral regurgitation is firstly to improve survival, and secondly, of course, importantly, to improve their quality of life and their symptoms, and thirdly, to avoid hospital admissions. So the problem in this case is that the heart failure is the primary pathology. It has in turn caused a volume overload from the leaking heart valve. So there's sort of a vicious cycle where the mitral regurgitation would cause progressive worsening of the heart failure. But in this condition, because the primary pathology is that of the heart failure, it is important to optimize them first on the heart failure medications. So they optimize their beta blockers, their ACE inhibitors, their angiotensin receptor neprilysin inhibitors, the MRAs, and the SGLT2, and to optimize them for at least 3 months, to watch for a response. And during this time, monitoring them closely, assessing whether they're responding to medical treatment clinically, and also by the markers such as the NT-proBNP and echocardiography, before considering other options, because they may not need the other options. This medical treatment may be sufficient to improve them. And if they are not responding to medical treatment after 3 months, then they are unlikely to respond. At that stage, you could consider further interventions from CRT, for example, if suitable, if they've got desynchrony or widened QRS on ECG, or valve surgery or device surgery, and other antiarrhythmics or an ICD. So this patient was optimized on a beta blocker. He was started on an angiotensin receptor neprilysin inhibitor, an ARNI, spironolactone, furosemide to offload him a bit because he was in pulmonary edema. He wasn't on an SGLT2 inhibitors, but he is now, after the evidence came out of the improvement in survival with SGLT2 inhibitors. So he was optimized on this, and he was monitored. And at every 3-month intervals, more frequently initially, but at every visit, he showed improvement in terms of a reduction in his NT-proBNP and his symptoms. And so he was maintained on medical treatment. So there's some data from the Paradigm heart failure trial, which shows that when you initiate treatment with either an ACE inhibitor or with sacubitril valsartan, there is a significant drop in NT-proBNP within about 2 weeks. And this reduction is sustained in the case of the sacubitril valsartan, but it's much better compared to the traditional enalapril ACE inhibitor. And when we look at this more closely, the dosage, the optimal dosage of the ARNIs is important. The optimal dosage is 200 milligrams twice a day. It may not be possible to start them on 200 milligrams twice a day straight away because there may be a bit of hypotensive. The renal function may be a bit borderline. So a lot of us would be cautious and start them at perhaps 100 milligrams twice a day, or even at 50 milligrams twice a day. But the important thing is to slowly titrate this upwards towards the maximum tolerated dose of 200 milligrams twice a day in order for it to exert its maximal effect of reversing the left ventricular remodeling. And this is a trial, the PRIME study, specifically looking at patients with functional mitral regurgitation, which did demonstrate that at 12 months with the salbutamol valsartan or Entresto, there was a significant reduction in the severity of mitral regurgitation, more so than those who were just treated with valsartan. The PRIME trial was a randomized trial comparing valsartan alone versus sacubitril valsartan in patients with functional mitral regurgitation and a dilated left ventricle. So this patient was maintained on that, and we were targeting medications which would hopefully interrupt all of these processes and not only interrupt it, but reverse it, and leading to reverse remodeling of the left ventricle, and in so doing, hopefully to prevent sudden cardiac death. This is 2 years later, so you can see that the patient is now asymptomatic. That same patient, his NT-proBNP had reduced to 280. His left ventricle improved significantly to EF is now 56%. The LV is in fact a normal size now. LV systolic diameter of 37 millimeter, end-diastolic diameter of 53 millimeter. The mitral regurgitation was mild in severity. He's now on the Entresto of 200 milligrams twice a day, bisoprolol of 10 milligrams once a day, spironolactone, and dapagliflozin. It is important, in my view, that even though the left ventricle has been, the heart is now of a normal size and function, that we maintain them on the heart failure medications. But we could perhaps discuss this in the question and answer session. But this patient has done very well just from medical treatment, and there are quite a few other examples of these patients who have responded remarkably well with just medical therapy. So this is just to compare the same patient. The top row shows what he was like 2 years ago, and the bottom one shows what he's like now 2 years after medical therapy. Now, but of course, not all patients will respond in this way. He is very fortunate. But as I said at the beginning, it's important to optimize their medications for at least 3 months and then evaluate. And if the trend at 3 months is that they are improving, then to persist with medical treatment. But if they're not, then we have to consider the options. And then that depends on a few things. The severity of the mitral regurgitation is one of them. So if we have improved their mitral regurgitation to at least mild, then there's definitely no indication for any intervention of the mitral valve. If we have reduced the severity of mitral regurgitation to moderate, then it is debatable what we do. There is still an intermediate risk of them having heart failure, hospitalizations, and progressive LV and LA remodeling, and a high risk that the mitral regurgitation would progress again to severe. But I think if the mitral regurgitation had improved to moderate, we would not then at that stage intervene on the mitral valve, but only if the mitral regurgitation remains as severe or moderate to severe, then we could consider some intervention on the mitral valve. Because if we left the patient with just medical treatment and moderately severe mitral regurgitation, then they are still at a very high risk of needing hospital rehospitalization, progressive mitral regurgitation, and also sudden cardiac death. So one of the options to offer patients who are not responding to medical treatment mitral valve repair surgery or mitral valve replacement surgery. And this is one of the studies which showed that you can do it at a low operative risk of 1.6%. And this is the results after mitral valve surgery. You can see a significant reduction in LV volumes and an improvement in their ejection fraction. And if we compare this towards patients who just have medical treatment, you can see that patients who have mitral valve surgery show a much significant improvement in terms of their reverse LV remodeling and reduction in LV volumes. We can also look at the trials on using the mitral clip. The mitral clip is a device closure of the mitral valve. In this case, this is the Mitral FR trial, a randomized trial comparing optimal medical treatment against optimal medical treatment plus the mitral clip. In this case, they demonstrated no difference in terms of their endpoints of all-cause mortality and unplanned rehospitalization for heart failure compared to optimal medical therapy. In contrast, this is another trial, the COAP trial, which looked at the same thing, and they also randomized patients with significant mitral regurgitation and heart failure to either continuing on medical therapy or having a device closure of the mitral regurgitation. And in this study, they showed that those who had the device closure of the or the device correction, the mitral clip of the mitral regurgitation, the hospitalization for heart failure decreased by about half, and their survival also improved. The death from any cause was reduced significantly in those who had the mitral clip compared to those who remain on optimal medical therapy. So the differences in results from these two studies is almost certainly due to different selection of patients, and it is thought that we have to look at a few parameters, and that functional mitral regurgitation is a bit more complex than just randomizing all these patients to medical treatment or intervention of the mitral valve. And there are really various categories of these patients which we need to consider, and we have to individualize the treatment to each patient. And we will go into this into a bit more detail in the next during the presentation. But one of the things which appear to be important is to look at the proportion, the severity of the mitral regurgitation and how proportionate it is to the dilatation of the ventricle. If you have a ventricle which is very dilated and the severity of the mitral regurgitation is in proportion to the dilatation of the ventricle, then it is likely that these patients would benefit with just medical treatment, and that correcting the mitral regurgitation may not be that advantageous. But if the severity of the mitral regurgitation is disproportionate, disproportionate to the degree of dilatation of the left ventricle, then it may be advantageous to correct the mitral regurgitation in these patients. So what we have seen in this example are very much patients in this group, patients with heart failure, reduced ejection fraction, or moderately reduced ejection fraction, where there is dilatation of the left ventricle causing leaflet restriction, some degree of dysynchrony, impaired LV contraction, lack of mitral valve leaflet coarctation, and this then results in mitral regurgitations with increased LA pressures, increased LV filling pressures, decreased contraction of the mitral annulus, and mitral annular dilatation. We can also get secondary or functional mitral regurgitation in those with preserved ejection fraction. This typically occurs in patients with atrial fibrillation. In chronic atrial fibrillation, you can get dilatation of the left atrium, and this results in dilatation of the mitral annulus without impaired contractility of the left ventricle. And so in these patients, you can get significant mitral regurgitation just from annular dilatation. Now, if that's the case, then in those patients, there is limited role for LV reverse remodeling or heart failure medications, because the left ventricle is normal in those patients. So those patients would benefit from valve repair surgery, and to correct the mitral regurgitation in those group of patients, we will just put in an annuloplasty ring. We have to put in an annuloplasty ring which is a bit smaller than the size of the normal annulus, what we call a reduction annuloplasty, or an undersized annuloplasty to improve the coaptation between the two leaflets of the mitral valve and to correct the mitral regurgitation. Some time ago, I had the opportunity to study in detail the normal annular and leaflet motion of the mitral valve during the normal cardiac cycle. And our cardiologists will know this from echocardiography. But if you look at it in detail, and this was a study using cardiac magnetic resonance, the mitral valve annulus is a dynamic structure. It gets smaller and bigger throughout the cardiac cycle, along with the mitral leaflets. And you can really divide that into 6 phases of the cardiac cycle. And the mitral annulus is smallest at the pre-systolic contraction and gets larger just before the onset of diastole. Now, this normal annular function of the mitral valve is lost in functional mitral regurgitation, as we can see here. This is in a normal healthy patient where you can see the size, the subtolateral diameter of the mitral annulus changes in size during the cardiac cycle. But in patients with functional mitral regurgitation, that annular contraction is lost. And this is again one of the mechanisms which contributes to mitral regurgitation in these patients. And that is another reason why we would put in a mitral annuloplasty ring, which is smaller than that actually size, to compensate for this loss of mitral annular contraction. So we come on then to another group of patients with functional mitral regurgitation due to ischemic heart disease, coronary artery disease, the functional ischemic mitral regurgitation. So in this group of patients, they have a myocardial infarction, and then the part of the ventricle which has a myocardial infarction is not able to contract. It remodels, and then it pulls the Pepperell muscle and the supporting leaflets apart, and therefore restricts the mitral leaflets, and therefore cause mitral regurgitation as a result. A so-called Carpentier type 3B mitral leaflet motion restriction during systole. And if the coronary disease is more extensive, if they have multivessel coronary artery disease, if the pre-vessel coronary artery disease, particularly involving the LAD and also the circumflex and the right coronary arteries, you can get a more uniform dilatation of the left ventricle, similar to what you see in dilated cardiomyopathy. So this is another example, another case. This is a 47-year-old man, and he becomes short of breath on malexertion. He was in CCS class 3, so he had angina as well on malexertion. He had autopnia, bilateral leg swelling. And you can see his LV was very dilated. The ejection fraction was impaired. The LV apex was non-viable. You can see there's even some thrombus here. This part was non-viable on cardiac MRI, and yet moderate functional mitral regurgitation, as you can see there. And this is his angiogram. You can see it's got very extensive coronary disease. His LAD was occluded, very poorly filling. The circumflex was critically stenosed, and his right coronary had significant stenosis at multiple sites. So a question for you, how would you manage this patient? By medical treatment only, or by medical treatment plus PCI, or with CABG, or with CABG plus mitral valve repair or replacement? Okay, that's interesting. So 68% feel you should have optimal medical therapy plus CABG plus a mitral valve repair or replacement. 11% thinks optimal medical therapy plus CABG. 17% thinks optimal medical therapy plus PCI. 4% thinks optimal medical. So let's carry on. So this patient was optimized on guideline-directed medical therapy for 1 month. It's important in these patients, even if you're considering surgery, that they are optimized for a period of time on medication for their heart failure. In this case, the patient had aspirin, bisoprolol, Entresto, and spironolactone. And in this case, in this patient with critical coronary disease, there is a balance between how long we manage them on heart failure treatment before we revascularize them, because during this period they are at risk of myocardial infarction and sudden cardiac death. So on balance, we probably shouldn't wait 3 months in patients with critical coronary disease, but a balance of 1 month is probably reasonable to get their heart function in a better shape before going for revascularization. In this patient, because of the severity of the coronary disease, PCI would have been technically very challenging and high risk as well. And bypass surgery would have been technically easier to do. And so he went for bypass surgery, and he had internal mammary artery to the LAD, a vein graft to the intermediate, a vein to the OM1, and a vein graft to the PDA. Interestingly, despite the poor LV, his Euro score worked out at 2%. So his risk of surgery was 2%. So the risk of bypass surgery has really improved a lot nowadays due to the better medication and better management, both preoperatively, intraoperatively, and also postoperatively for these patients. So this is his echo 2 years later after his surgery. He is now asymptomatic. His ejection fraction had improved to 35%, and he had no mitral regurgitation. You note that we did not do a mitral repair, and we will go into this in the next few slides. So this patient's mitral regurgitation, this is just to compare his echo before surgery and 2 years later. So his mitral regurgitation improved with just revascularization, and of course with optimal medical treatment, which has to be continued even after surgery. So if we look at the trials to guide us on how best to treat these patients, this is data from the STITCH trial, looking at patients with ischemic heart failure, and you can see that patients like this patient who had ischemic heart failure, their long-term survival is improved significantly if they have CABG in addition to optimal medical therapy. And this is a meta-analysis of all the trials on heart failure, and you can see that the survival is much improved in those who have CABG compared to just those who just have medical therapy. And comparing and the same goes for the hospital admissions for heart failure. You reduce that if you revascularize them by CABG. And we compare CABG against PCI, the survival is better in this group of patients who have ischemic heart failure because there's a more complete revascularization. And if you compare CABG against the drug-eluting stents, survival is also better in those who have CABG in presence of heart failure, as well as the incidence of myocardial infarction is reduced following CABG compared to PCI, and so is the risk of repeat revascularization. So the evidence for CABG is very strong. There is level 1 evidence to support CABG. So this is another case, case number 4. This is a 81-year-old man, previously a very fit 81-year-old. He was doing his gardening and very active, and then he suddenly became short of breath over a few weeks. He was then short of breath on mild exertion, and he had chest pain on mild exertion. His left ventricle had dilated, not as much as the previous case, but it was dilated. EF was down to 40%. And his mitral regurgitation was severe, a lot worse than the previous case, with an ERO of 0.6. And this is his coronary angiogram. So you can see a tight left main stenosis there, multiple stenosis in the LAD, critical stenosis of the circumflex and diagonal, and his right coronary was occluded. So a question for you, how would you manage this patient? Optimal medical treatment only, or with PCI, or with CABG, or with CABG plus a mitral valve repair, or CABG plus mitral valve replacement? Okay, so we are a bit split here. So 37% thinks CABG plus mitral repair, 24% CABG plus mitral valve replacement. Actually, we're not that split because 60% thinks we should intervene on the mitral valve in addition to CABG. 12% thinks should have CABG. 22% thinks PCI is good. So in this case, we did do CABG and a mitral valve repair. And this is his echo 2 years later. He's asymptomatic. His LV had returned to a normal size with normal function, and he has no mitral regurgitation. And he's back to gardening and doing everything he likes. His quality of life is very good. So he's done very well from revascularization plus mitral valve repair in this case. And importantly, with continuation of his medical treatment. So if we look at the natural history of ischemic mitral regurgitation, we see that patients with even mild degrees of mitral regurgitation have an increased probability of death compared to those who have no mitral regurgitation. And obviously, if they have moderate or severe mitral regurgitation, then they have a significantly increased probability of death, and also an increased risk of heart failure admissions if they have more than mild ischemic mitral regurgitation. And this does not seem to be improved fully with revascularization. As you can see from this study, after CABG, if they have residual moderate mitral regurgitation or even mild mitral regurgitation, then there is an independent predictor of reduced survival at 5 years after CABG. So as in non-ischemic heart failure, the aims of intervention is similar. Firstly, to improve their survival. Secondly, to improve their symptoms and quality of life. And thirdly, to avoid hospital admissions. So the intervention which would improve their heart failure or their survival is the optimal medical treatment. And they also need revascularization for their coronary artery disease and intervention on the mitral valve if it is significant. And for the best outcome in these patients, all of these three conditions must be addressed. But as I mentioned earlier, ischemic mitral regurgitation is a heterogeneous condition because we have different degrees of severity. We have mild, moderate, severe, and very severe, different degrees of mitral-related tethering, different degrees of LV size, geometry, function, and viability. So a tailored approach is needed. So first of all, in the last two cases, we have to decide, is an intervention on the mitral valve needed? In the last case, we did intervene on the mitral valve. The earlier case, we just left it alone and just revascularized it. So what determines the need for revascularization? The severity of the mitral regurgitation is one of them. If it is severe or very severe, then some intervention is advisable at the time of revascularization, and also the degree of LV viability. If the mitral regurgitation is moderate in severity and all of the LV is viable, then you could probably not repair the mitral valve. But if the LV was showing large areas of non-viable segments, particularly in the segments supporting the papillary muscles, then the mitral regurgitation is unlikely to improve with just revascularization. And in that case, it is beneficial to repair the mitral valve at the same time. If the mitral regurgitation is mild, then there's no need to intervene on the mitral valve. And then we have to decide on the type of mitral valve intervention, whether we repair the valve or replace the mitral valve. And to help us answer that question, we have to look at firstly the degree of severity. If it's only moderately severe, then usually we do not need to repair it. We can repair it very successfully. But if it is very severe mitral regurgitation and there's severe tearing of the leaflets or severe dilatation of the LV and distortion of its geometry, then in those cases, it may be necessary to replace the mitral valve. So in mild mitral regurgitation, optimal medical treatment and revascularization if indicated. Don't forget, not all coronary disease needs revascularization. Some of them, if it's not too severe, can be treated with just medications, and no intervention is needed on the mitral valve. Moderate mitral regurgitation, half of them improve with just revascularization, the other half do not. So in these patients, it depends on the amount of viable LV segments. If all of them is viable, then there's no need to intervene on the mitral valve. But if there's more than 4 non-viable inferior LV wall segments, then intervention of the mitral valve is beneficial. So this is another case. This is a 51-year-old man. He was in NYHA class 3, so that he's short of breath on mild exertion. He had 3-vessel coronary artery disease, moderate mitral regurgitation, and you can see on the cardiac MRI, non-viable inferior LV wall. It is highlighting with gadoliniums. So in this case, he had 4 bypass grafts and a mitral annuloplasty. Because the non-viable segments is the segment supporting the pepperine muscle. We can see that very clearly. The pepperine muscle is attached to the non-viable segment. So the patient is unlikely to show an improvement in the mitral regurgitation with just revascularization, and intervention on the mitral valve is needed. But I think I've given you the answer to this question. But anyway, we can take the poll. How would you manage this patient? Just optimal medical treatment, or with PCI, or with CABG, or with CABG plus a mitral valve repair or replacement? Okay, so the split between repair and replacement. 90% thinks we should either repair or replace it. Yes, it is true that in ischemic mitral regurgitation, the benefits of repair versus replacement is not as strong as in degenerative mitral regurgitation, where repair is definitely better compared to replacement. But in ischemic mitral regurgitation, it may be just as good to replace the mitral valve in some cases. So this is results from the RHYME trial, the randomized ischemic mitral evaluation trial, which I had the privilege of leading some years ago when I was in London. And essentially, this was a randomized trial between CABG alone versus CABG plus a mitral valve repair by an annuloplasty in patients with a moderate degree of mitral regurgitation, an ERO of about 0.2, and multi-vessel, 3-vessel coronary artery disease, and with some moderate dilatation of the left ventricle and moderate impairment of the LV function. And these patients also had non-viable LV in at least 4 segments, typically in the inferior posterior segments of the LV. And they had tethering, but the tethering was not severely tethered. We consider tethering to be very severe if it's greater than 10 millimeter. So in this study, the tethering distance was 7.7 millimeter in the patients. And in this study, we did demonstrate a significant benefit with adding mitral valve repair surgery to CABG in terms of their improvement in functional capacity as measured by peak oxygen consumption, where those who had the valve repair in addition to CABG demonstrated a 22% improvement in peak oxygen consumption compared to those who had CABG who showed a non-insignificant 5% improvement. And along with this, there was greater reductions in mitral regurgitant volumes if they had the valve repair. They also had less mitral regurgitation. Most of them had no mitral regurgitation or only mild mitral regurgitation compared to those who continued to have moderate mitral regurgitation if they just had CABG. And there was also greater reduction in LV volumes as measured by cardiac MRI in those who had the valve repair compared to those who just had CABG, and a greater reduction in NT-proBNP levels in those who had the valve repair compared to those who had CABG. And importantly, the patients who had the valve repair felt better. Most of them were in NYHA class 1 compared to those who had CABG who remain in NYHA class 2 at 12 months. So this is another study. This is from the US moderate ischemic MR trial, which looked at exactly the same question and did the same randomization. In this study, interestingly, they did not do cardiac MRI, so we have no information on viability of the LV wall, but they did look at wall motion score index, and you can by echocardiography, and you can see that at baseline they had the akinesia of the inferior inferior lateral wall, and at 2 years this had improved significantly after revascularization. So this does suggest, even though they had not assessed viability, but the fact that the LV improved in wall motion, that these patients largely had viable myocardiums. And that is where our knowledge now of the importance of determining LV viability to help guide the need for intervention on the mitral valve in this patient arises. Because in this study, you can see that in patients who had CABG, all of them had moderate MR to start with, but at 2 years, only 30% of them had moderate MR. So 70% of the patients had improved their mitral regurgitation severity just with revascularization without mitral valve repair. And that is almost certainly because these patients had viable myocardium at the time of revascularization. So in this study, they did not show any difference between CABG alone or CABG plus mitral valve repair in terms of LV volumes. And so we know now that if the LV is viable in the presence of moderate ischemic MR, it's probably quite safe to leave the mitral valve alone and just to revascularize the coronary arteries. If we to put all the 3 trials, the RHYME trial is the first trial, the US trial is Smith, and there's also an Italian randomized trial on this subject. You can see that adding a mitral valve repair to CABG does not increase perioperative mortality. It did not improve survival either, but bear in mind that even when we combine all 3 trials, the studies were still not sufficiently powered to detect a difference in survival. It's because there were only 474 patients in the study, so it is still not powered for survival. But what it does show is that we do reduce the MR severity, and by that it should translate to an improvement in at least the symptoms for the patients and quality of life, and probably also their survival in the longer term. In the case of severe mitral regurgitation, then the decision of whether we know that we have to intervene on the mitral valve, but the decision on whether to repair or replace the mitral valve, that depends on the risk factors for recurrent mitral regurgitation. So we have identified factors which would predict a recurrence of mitral regurgitation after mitral valve repair surgery. And if they have these risk factors, then it is better to replace the mitral valve rather than repair the mitral valve. Or if we want to repair the mitral valve, then we have to do some additional repair techniques besides just an endocyzed annuloplasty. And the predictors of recurrent mitral regurgitation following mitral annuloplasty for severe ischemic MR are this. They're divided into 2 broad categories. The tethering indices, how tethered the leaflets are, and the easiest to measure is the coaptation or the tethering distance if it is greater than 10 millimeters. And also the LV size and geometry, if the LV is dilated to more than 65 millimeters, or in the presence of LV, basal LV aneurysm, then that is a risk factor for recurrence of mitral regurgitation. So in this group of patients, it's probably better to replace the mitral valve rather than replace it. So there are various techniques to repair the mitral valve, which I won't go into. So to summarize ischemic MR, mild ischemic MR, just revascularize only, and optimal medical therapy, revascularize if appropriate, and optimal medical therapy. Moderate ischemic MR depend on the LV viability. If all LV wall segments are viable, then just coronary revascularization. If there's significant non-viable inferior LV wall segments, then repair the mitral valve as well, in addition to CVG plus optimal medical therapy. In severe ischemic mitral regurgitation, look at the tethering distance and the LV size. If it's not too severely tethered and the LV end diastolic diameter is less than 65 millimeter, then repair the mitral valve in addition to CABG and optimal medical therapy. If the tethering distance is more than 1 centimeter and the end tethering distance is end diastolic diameter is more than 65 millimeter, then replace the mitral valve plus CABG and optimal medical therapy. I think because we are overrun a bit, we might skip the tricuspid regurgitation if that's okay. So take-home message: optimal management of valvular heart disease is dependent on the etiology of the disease. Primary degenerative mitral regurgitation is best treated by mitral valve repair surgery when severe. Secondary functional mitral regurgitation is best optimized on guideline-directed medical treatment before considering any surgical or device intervention. In secondary functional ischemic mitral regurgitation, coronary artery revascularization is important in addition to guideline-directed medical treatment. Mitral valve intervention is beneficial in severe ischemic mitral regurgitation or moderate ischemic mitral regurgitation in the presence of non-viable myocardium. We didn't go through tricuspid valve repair, but just to summarize, tricuspid valve repair should be considered at the time of mitral valve surgery if it is moderate or more in severity, especially if associated with tricuspid annular dilatation. So this is a book I wrote. I'm so interested in this subject that I have a book. If you're interested, you can read through this book. It's not too thick a book, and I think it is very readable. It does summarize all the concept. It needs to be updated because a lot of the advances have occurred, particularly in the medical therapy with the neprilysin inhibitors and also the SGLT2 inhibitors. So a second edition is due hopefully next year. But I think if you're interested, do read this book. And I'd like to thank you for participating, for joining us today. Thank you again to Novartis also for organizing this. I'm happy to take any questions if you have any. Thank you very much.
Thank you, John. It was an interesting talk. I would like to invite those who are listening to put forward any questions. So far, I think we have one question, but maybe before we address this question, there was something I thought that you mentioned, John, about the MITRA France and the COAP trial regarding mitral clip for severe MR in patients with heart failure. So you did say that for the mitral FR, there didn't seem to be any difference in the primary endpoint, whereas with the COAP, there was a difference. Whether that is related to the question that is being addressed about the assessment of disproportionate MR. Maybe you would like to touch on that.
Yeah, I think it is related. So we don't actually know the reason, but since those two trials have been done, a lot of sub-analysis have been done on the data. And what is emerging to emerge is that there are several important differences in the trials. And all of these, when added together, may well explain the differences. So one of them is the role of medical treatment, because in the protocol of the COAP trial, it was mandated that the patients have to be stabilized on guideline-directed medical therapy for, I think, at least 6 weeks. whereas this was not mandated in the Mitral FR trial. So it is possible that in the co-op trial, the patients had already tried the optimal medical therapy, similar to what actually was presented, that they had already been optimized on this, and then they were found to be still not responding to medical therapy, and then they were entered into the trial. So in that group of patients, it is likely that they would benefit from intervention on the mitral valve because they are already not responding to medical therapy. Whereas in the mitral FR trial, it appears that because the stabilization of medical therapy wasn't mandated, it is possible that a proportion of those patients could have benefited just with medical therapy. So that's why they probably didn't show the benefit, because they had not confined their patient to only those who did not respond to medical treatment. And then the other thing they found was that the patients in the quad trial had greater severity of mitral regurgitation when you compare that to the severity of how dilated the left ventricle was. So in other words, they had a greater, so if you have greater MR, mitral regurgitation, and you stop that through any intervention, then that is likely to have a more significant impact in terms of reversing the left ventricle dilatation. Whereas in the mitral quad trial, the mitral FR trial, they did a mitral regurgitation, but it wasn't as bad as the quad trial, and also when it was as bad as the quad trial, the ventricles were a lot bigger. So in other words, the ventricle, the MR severity was in proportion to how dilated the ventricle was. So we now know that in those group of patients, probably we should optimize them on medical therapy first, because those are the group of patients who are likely to show some significant response to medical treatment compared to needing some intervention on the mitral valve.
Yeah. So I think in answer to the question about disproportionate MR, it would be that if the ventricle is very enlarged, then you would expect MR to be more because of annular dilatation. And I think in the COAP trial, they excluded patients with LV more than 7, and in patients with class D or very severe advanced heart failure. So maybe those patients are too far gone. So if the ventricle is not so bad, but the MR is bad, treating the MR may be beneficial for the patient. So just out of interest, since there is this option of mitral clip, and if you have a patient with dilated cardiomyopathy with an EF of 30% and a severe MR, so out of proportion MR, would you consider mitral valve repair alone, or would you think mitral clip may do better than surgery?
Yeah, I think we need there's not to date no direct comparison between valve repair surgery and mitral clip. I think the important thing is to get rid of the mitral regurgitation, because particularly if you have a patient in heart failure, then the presence of mitral regurgitation can prevent the LV reverse remodeling. So you have to interrupt that cycle in those patients who are not responding to medical therapy, interrupt that cycle of the mitral regurgitation to allow the LV reverse remodeling to occur. So a lot depends on achieving minimal residual mitral regurgitation, either by valve repair surgery or with the mitral clip, which is a form of valve repair surgery. So I think it is okay to leave them with mild. In the case of degenerative MR, you shouldn't even leave them with mild MR. We can learn from the studies in degenerative mitral regurgitation, where even the presence of mild degenerative residual mitral regurgitation has an impact on long-term outcomes. So I think we can imply the same for those in the functional MR group. We certainly shouldn't leave more than moderate mitral regurgitation, moderate residual mitral regurgitation. So if we can get rid of the mitral regurgitation through the mitral clip, then I think that is likely to show a very good result. Conceptually, the way the mitral clip works is an edge-to-edge, is an extended edge-to-edge technique to get rid of the mitral regurgitation. And conceptually, that will work. The mitral clip, I think, will work for functional MR, because that is how we would actually repair the mitral valve for functional MR with very severely tattered leaflets. So conceptually, the mitral valve, the mitral clip should be successful. There may be some improvement in the design of the mitral clip may be needed, but I think it will be achievable to treat functional MR with the mitral clip. I think that will be one of the indications, successful indications for use of the mitral clip. But of course, we need the data. At the moment, we don't have data beyond 5 years for functional MR to demonstrate that it is beneficial. But in this group of patients who are very sick, even if we reduce the mitral regurgitation, I think it will probably help these patients.
There's another question to be addressed. For degenerative mitral valve disease with depressed ejection fraction, do we consider medical therapy first or surgery as soon as possible? Which would be a better approach?
Yeah, so this depends on the condition of the patient. Generally, if the LV is already impaired, whether this is from valve regurgitation or coronary disease, it's better to optimize the heart failure first with medication, because then you can get the LV into a stronger condition and you can reduce the risk of the surgery. Surgery to repair the valve is still needed because you have a primary mechanical problem. And until surgery, the patient will still be at continued risk of heart failure. But I think a period of time, optimizing the LV would be beneficial. This is in the patients in whom the heart failure has occurred gradually over time. But we do get patients, usually the elderly patients, where the cord will suddenly rupture and then they develop severe mitral regurgitation quite acutely. And then they are quite symptomatic. You get them a bit better with medication. Now, in those patients, you generally cannot wait too long because the time for them to have progressed from mild mitral regurgitation to severe is very short. So the ventricle has not had time to adapt. So you can buy some time with the medications, but you can't wait too long. So that period of stabilization in that group of patients may need to be a bit shorter. But there's always, and then of course you have the extreme where patients with an acute rupture of the cordae, severe MR, and they truly become very decompensated because the heart had not had time to compensate. Typically in patients with endocarditis, for example, in which you cannot even stabilize the patient on heart failure medication, and you need to do surgery quite urgently. So there are different groups of patients. But I think in general, if you can stabilize them, that is the better approach. And then you have to strike a balance between how long you can stabilize them for before surgery and doing the surgery.
Okay, and then there's a question about viability. So I presume this is in reference to coronary artery disease patients with heart failure, with or without mitral regurgitation, for example. Would you require a viability study before you consider intervention?
Yeah, before you consider coronary intervention, I think, because if you're not considering coronary intervention, you're not doing a viability study as such, but it may be useful to look at the presence of fibrosis, for example, in dilated cardiomyopathy, because that can give you an idea of the outcomes for this patient and how much intervention you may need. So the answer to this question, in the patients with ischemic heart failure, generally we would want a viability study, but it then depends on the assessments you have done, because you do not necessarily need a special viability study. In an echocardiography, I think you can most often tell, or you can tell in a lot of cases whether the LV is viable or not. because if the airway is contracting in that area, it is viable, even though if it's hypokinetic. So we have, so in answer to that question, I think we do not always need a viability study, but it is useful in many cases, particularly in areas where you want to decide whether you just revascularize or you want to intervene on the valve as well.
Okay. There's a question about atrial dilatation as a contribution to MR, and what is the management for this? Because we always thought that it's due to annular dilatation related to the ventricle, but you mentioned about atrial dilatation. So I was also curious, and somebody has brought up this topic. So if you think that the atrial component is contributing to MR, is there any specific treatment for this group of patients?
These are interesting group, because over the years we have found a lot of these patients, and we used to wonder why the functional, I mean, the airway is completely normal. During surgery, there's no leaflet prolapse. It's a pure annular dilatation. But most of these patients are in atrial fibrillation. And recently, in the last few years, a lot of several studies have come up describing this problem with and have been published. And the diagram I showed just now is actually a review article on this. So this group of patients, if they have significant mitral regurgitation, is not going to get better with medication. So this group of patients will need a mitral valve repair to get rid of the mitral regurgitation. So in answer to your question, in this particular group of patients, there is actually no medical treatment as such, but they will need surgery to correct the mitral regurgitation.
Okay, and there's a question about who are candidates for mitral clip. I presume it will probably refer to patients with heart failure, the groups that we talked about, the COAP. But I guess there's been also other users of mitral clip out of the setting of impaired LV function.
Yeah, very excellent question. I was fortunate. We are actually doing some guidelines. I don't know if some of those on the Asia Pacific Society of Cardiology may be on here, but I was on the guideline committee, and we are doing the guidelines to help guide cardiologists and physicians on the indications for the mitral clip. Hopefully this will be published in the next few months. But in the meantime, we can refer to the European and American guidelines. And at the moment, the guidelines are quite clear that the mitral clip is recommended in those who are not fit for the normal surgery. So so they should first of all be considered for the conventional mitral valve repair surgery. Only if they've been turned down for mitral valve repair surgery or replacement surgery, then the mitral clip is an option to consider. And the reason for this is that we do not have long-term data on the mitral clip. There's some concern about the residual mitral regurgitation. So at the moment, so patients who have, so for example, elderly patients or those with a lot of comorbidities, they can be considered for the mitral clip. When the mitral clip was first introduced years ago, for some reason, they excluded the functional MR patients, and it was used for degenerative mitral regurgitation. And the